So good afternoon. Welcome to Project Echo. Today is Wednesday, November the 19th. For today's agenda, we will have a discussion from Dr. Clark Allen on hepatitis C treatment interruptions and retreatment. And then we will also have two case presentations and an opportunity for Q&A. If you are interested in receiving the continuing education credit for participation in today's session, please make sure that you have registered through the Southeast AIDS Education and Training Center. You can use the QR code attached here, or you can use the link. Kimber has also dropped the information in the chat. You do have to participate in the full session in order to receive the credit. There will be an evaluation link at the very end, and then you can complete that and receive your certificate at a later time. Just a few reminders during today's session. If you do have any technical issues, especially with Zoom or audio or anything like that, please make sure that you reach out and private chat Kimber Miller. She has dropped her information in the chat for you. And while we do still have some folks joining, I wanted to take just a second since this is the last session before Thanksgiving. And we've been having some icebreakers. We've had some fast facts, some trivia in previous sessions. But for today's, I just wanted to take a moment and allow you the opportunity to kind of reflect on what you are most thankful for this season. You don't have to necessarily add your information in the chat if you don't want to, but just take a moment to reflect on that while we continue to have folks join. All right, we'll go ahead and move forward. So as I mentioned earlier, if you have just joined, our session today will be on hepatitis C treatment, interruptions, and retreatment by Dr. Clark Allen. And Dr. Allen, I'm going to go ahead and turn it over to you.
All right. Thanks for the introduction. So, like she said, yeah, we're going to look at a couple of things. We've mentioned interruptions before. We'll focus on it again today at more length, along with patient case. Talk about a little bit of resistance and also retreatment today. Next slide. No conflicts of interest to discuss with the presentation today. Next slide. We've got a couple of abbreviations today. Most of them are typical, some are not. The first thing, hepatitis C virus, I left off the initial one, so not just hepatitis. TBI involves a patient case, traumatic brain injury, and then we actually break down the NS5A, NS5B, and NS3A4 proteins. So those stand for non-structural proteins in the hepatitis C virus. So I wanted to make sure I explain what those are when I start talking about those in the presentation. Next slide. Objectives today, we want to look at potential causes of what leads to treatment interruptions, identify resistance testing when it should be considered, and also determine what to do as far as best options when we need to consider retreatment. Next slide. So the first thing, we'll go ahead and next slide, and we'll look at an audience poll. We want to open it up. First things first, we want to, not that, since we didn't have an icebreaker, we're going to have an icebreaker here. What are, if for clinicians out there that do treat hepatitis C right now, what are some of the reasons that you've experienced treatment interruptions in the patients that you've kind of initiated treatment on, or have you seen treatment interruptions or potential interruptions that you've could be potentials for you? What I want to kind of open it up, get some thoughts out there. Okay, incarceration. Yeah, when patients sometimes not unexpectedly have to go to jail or go to prison, that can definitely be an issue. Substance use or abuse, that coming back into the fray. Side effects, hospitalization. Yep, lots of good things. Phone being turned off, can't find them. Yep, that happens a lot. Um, I try to always I give my business card out to patients at the initial visit, not to expect people to change phone numbers, but I just tell patients that in the event that you were to change phone numbers, I want you to have my phone number on how to get back to me. So I try to give all avenues of how to reach people and how they can reach me if they, for whatever reason, change phones and then I can't find them. Having a way to get back to me is always something valuable to present to your patients. All right, I think that's slowing off in the chat, so we can go to the next slide and wanted to point out things that I have experienced along the way of treating hepatitis C. I think we're in year 7 for me. So lots of different things that I've seen. These are the most common ones that I've seen. Social factors could be mental health, substance use or abuse, forgetting the medication, noncompliance, side effects, whether they're afraid of the side effects or, like somebody said, or just experiencing side effects in general, wanting to stop, not wanting to experience those things at all. Money, affordability, copays, those are a real thing. We try to navigate those things the best we can to anticipate those things before we start treatment. Legal things such as incarceration, medical, hospitalizations, unexpected things like that can come into play. And then insurance as well, whether it be changing insurance, which that happens, especially at the end of the year. So that's the main thing I wanted to bring the point across now is that patients who are starting on treatment now, make them aware or prompt them if they're changing insurance plans at the beginning of the year. Be aware of that you will have to do a new authorization to continue that treatment into the new year. Specialty pharmacy could change. Lots of things that could happen in that scenario. So right now, I'm asking each patient, do you know if you're changing insurance at the beginning of the year, to kind of start that ball rolling, to have them reach out to me when they get their new insurance card, to just try to prevent those pitfalls from happening, because those are just logistical things that are can be planned for ahead of time. So those are kind of the main things that I have experienced as far as things that interrupt treatment. Most common episodes of non-adherence in this scenario are usually in the 1 to 2 day range. This is kind of from reported literature, and then 11% of the time, more than 7 days, is potential for non-adherence as well. But we still have great SVR12 sustained viral response cure rates, even for patients who have episodes of interruption or missed doses along the way, still around 94%. So even if you have patients that are missing doses, we tell them to just reiterate the fact of compliance is important. We still have good cure rates, even if they're missing a couple of days, just trying to remember to stay with them along the way. Got a question in the chat before we go. Clarify, please. Need a new PA in the new year if no treatment interruption, or need it every year. Just if they're changing insurance plans. So if they're on the same plan, that PA will be good through for the duration of that PA if it goes into next year. It's only if they're changing insurances, especially with Medicare patients, they will change insurance plans, maybe from Cigna, Humana, United Healthcare. It can change between the any one of those, and that's when the new insurance has no idea that they're on medication, and so you're going to have to be on top of your game. That right when it's active, submit a new PA, find out if it needs to go to a different pharmacy, because sometimes that happens, not necessarily with Medicare patients, but with commercial plans, they can have being locked into a specific specialty pharmacy. Those are things that I would want to be aware of. So just keep that in the back of your mind of trying to make sure we don't have any hiccups in treatment just because of an insurance change. Great question. All right, next slide. So this is something we've seen several times already in the echo sessions, but if this is your first time here, this is something that's in the guidelines. It's readily available. You don't have to screenshot this. This is something you can find. So if you come across a patient that you're treating for hepatitis C and they have an interruption for less than 7 days, more than 7 days, depending on how long they've been on treatment, there's different pathways of how you should go about continuing that patient or potentially stopping. The main difference between these two groups, it's first 28 days versus after 28 days. And it's kind of the second part at the very bottom is where they change is if there's a viral load positive greater than 28 days after they've already received treatment, you may want to consider stopping and then moving on to retreatment options because you want to consider them potentially a treatment failure at that point if they're missing doses and got a viral load that's still detectable and they're missing a lot of doses, 8 to 20, if not more. And of course, if it's 21 days or more, you want to stop, check a viral load, and see where they're at. And if it's not detectable, maybe we can call them cured. Make sure it's been more than 12 weeks since they've stopped medicine, since they've missed their final dose. And then maybe if it's still present, we want to consider retreatment, and we'll talk about that later in this presentation. Next slide. So let's talk about a patient case that has come across my clinic very recently, and it kind of goes along with this information that's in the guidelines. So 26-year-old African-American male on sulfoxaflor with Hepatitis for 12 weeks, started in February. Patient lives with his parents due to support. He's had a recent TBI. He had an accident, traumatic brain injury. He had all three refills shipped out appropriately to his house. Always spoke to his dad. Everything was going smoothly. A patient returns to clinic in August for SVR12, which I didn't have any issues getting the medication, so I assumed there was 100% compliance. He living with his parents, so I didn't have anything to think that there was something an issue with this patient case. However, when he gets to the clinic visit, he reports he left his patient's parents' house and was homeless after taking the first bottle. He was either found or returned home in July, restarted the course because his mom still had the medicine at the house, restarted the course before he came to clinic and was already on the medicine 10 days before he came to clinic. So now I'm in a conundrum of what do I do now? I want to kind of pitch it to you guys based on what we just talked about in the previous slide. What do you think I should do? Should I stop and check a viral load, even though he's already been on medicine again for 10 days? Like he restarted the course without coming to clinic, without notifying the clinic. But should we stop the course, check a viral load now, or should we just continue on what the current course he's already restarted on his own? I want to get some thoughts and ideas in the chat. Maybe nobody's sure what to do. If nobody's sure, we can go to the next slide and
Dr.
let's talk
Allen.
about it. Yeah.
So just to clarify, because I'm looking at this myself.
Yeah.
Okay, so he started in February.
Yes.
He took the first dose or the
Right.
first bottle,
Mm-hmm.
and then he missed second and third bottle, but
Correct.
restarted the second bottle in July.
July. Correct.
Okay, so that would be about 4 months is what was missed
Yeah, he was off medicine for
for 4 months.
4 months. Yes.
Okay, I'm gonna personally vote with Kimberly. She said stop it and check SVR 12.
Okay. All right. That's a missed 21 days. Okay. All right. Let's go to the next slide because I know what you're saying, Kimberly. But I think, based on what information we were given, he was only took one bottle. So I'm going to assume we're still in the first 28 days of therapy. So he only took one bottle. Don't know if it's 100% compliance. I'm going to assume it is based on he was at his parents' house. So if he missed more than 8 days, but then he restarted the course, I'm going to go with if it's if they're able to obtain RNA tests as soon as possible, that would be great. Preferably same day as restarting. We weren't able to do that because he already restarted the course. But I'm going to say he falls into this category of missing greater than 8 days because he didn't finish the course. He only saw a bottle of medicine. So when I think about this, I think that we're just going to call this incomplete treatment, and we would just restart a new course of the medication, or we could switch agents. So I get what Kimberly's saying, that we can push forward, or we can go back 2 slides to where both of the diagrams on the same page. So that missed greater than 21 consecutive days, we want to stop and check a SVR12. That is only if they're greater than 28 days into the medicine. So I would say he was still 28 days or less on the medicine. So I would still say he's on the left side of the column versus on the right side because of that. Because I know he only took one bottle. That's what he said, and they still had the medicine. So great question. That's why I like to have dialogue with this because it's a tricky situation because him starting the medicine 10 days before he came to clinic, it threw a wrench in everything that I had to think about because I had to just go back to the guidelines, look at what he took versus what he's doing now, and then talk with the physician to make sure we were on the same page before we moved forward. Okay, so now we can push forward and go to the patient case continue slide. So add another riff to it. So now the patient no longer has insurance when he returns to clinic in July. So the medicine is at his house. We don't have the same insurance plan. We got him signed up for patient assistance because we wanted to just continue the current course that he restarted. So he had 2 boxes left because he's on generic sulfosylrobatispir. So I'm just going to get him one more box on patient assistance to complete a 12-week course on the restart. So the patient's dad reports that there's only 1 box left at the house and not 2 as I originally expected. So I was unable to, they're not sure what happened, but they're very confident he only took 1 box. And the patient said this, both parents said this, but they don't know where the third box went. So now we're in a now we're in the gray area because now I don't know what to really determine with this. So does this information change your planned course of action? So this is kind of where Kimberly's thought process comes into play. Is do we want to say did this patient take more than a box and maybe took maybe 6 weeks before he kind of left the house and went on his own? Like we don't know how much he did or did not take of that second box. So then it becomes a gray area. But the fact that he's already started the medication course again was the rip because I wanted to check a viral load when he came to clinic that day, but I could have, but I knew if he was 100% compliance for 10 days, I know based on experience, if I check a viral load 10 days into the course, it's probably going to be either 20 or not detectable. It's going to be very low based on my experience. So I knew that viral load wasn't going to tell me much as far as did it cure the previous course, or is it just not detectable right now after taking 10 days? So I was kind of stuck between a rock and a hard place. So we can go to the next slide and kind of flesh this out further. So this comes into play is if he got more than 28 days on that first one, we're supposed to stop and go to retreatment. But because he'd already started the course, I was kind of handcuffed. And so me and the physician talked about, and we've talked about it in the past, of sometimes even if they've considered treatment experienced or treatment failure, we can still try a first line agent. The cure rate may not be as good as if we went to retreatment, which we're going to talk about here shortly, but he's still got a good chance of cure if we know he's going to be 100% compliant this time. So me and the physician, we talked and we just agreed to just because was already on the medicine course for 10 days, we just continued the course and I got patient assistance to approve the second 2 boxes. And I actually, what we did is we took it a step further. Is there is some language here about extending the course 4 weeks, even though he doesn't have genotype 3 or cirrhosis. He was just genotype 1A with no fibrosis. Because he's in a gray area, we kind of flexed the rules a little bit and extended the course by 4 weeks. So we allowed him to take his 1 box that he had at home and then allowed him to complete another full course of medicine from patient assistance. So he got an additional 4 weeks on top of that to give us the best chance of cure. Now, of course, if this doesn't work, we will indeed go to Vosevi at that point. But we just feel like because he'd already started the treatment, we didn't want to halt it and then just start Vosevi at that point. We just allowed him to continue the current course he was on. So now we can. Any questions about? Okay, question was what was the initial viral load? It might take me a minute to get to that. 1 second, Bill. Let's see. His initial viral load was 1.9 million. So basically 2 million, genotype 1A, fibrosis F0. He was he's about 25-year-old male, so I didn't expect there to be any fibrosis. what's your thoughts, Bill? You got any more um, kind of to expound upon asking about the original viral load?
Yeah, considering I'd remembered he was young, but if it was really low, um, 4 weeks might have cleared it, and I was kind of dovetailing into would he be able to get any, and that would vary depending. My thought process would vary depending on whether he was able to get more meds through patient assistance or not. So the fact that he was able to get it, it kind of becomes a no-go. But if he was, he's a young guy, and if he had a lower viral load, his antibodies were keeping the virus at bay. 4 weeks might have cured him. And if he was not able to get any meds on patient assistance, possibly, waiting 3 months and checking for an SVR if it was going to be costly to the patient might not have been a bad strategy at that point.
Yeah, I agree with that. Yeah, like I said, I wish we could have checked the viral load before he restarted the course because that would have told us a lot. That would have told us, yeah, did that first course of only 4 weeks work? Because I've seen it work. Doesn't happen very often, but I know it works. We know these drugs are very good, but we do know that the cure rates are 95% or 98% effective if you take the full course. Doesn't mean that cure rates aren't maybe 70s. I have no idea what I'm not going to, I shouldn't throw out numbers. I don't know what the cure rates are for taking 4 weeks, but I do know it's possible just because anecdotal evidence, I've seen it happen. So there is a potential, but because he had already restarted, we just said, well, we'll just continue the course that we're on. And yeah, I think that would have been even harder to explain if he was on the same insurance. I think I would have been in a conundrum and maybe just told him to stop the course and we just check a viral load. That would have been a totally different scenario. If he was on the same insurance plan that we'd already done a full course, I would have probably had to tell him to stop because we need to reevaluate. And then we'd probably go to retreatment options at that point. Just because being on the same insurance plan and try to explain this, I don't think that they're going to see it as very black and white. They're not going to understand. So yeah, very unique case. So yeah, let's go ahead and go to the next slide to kind of see where we're at now. So right now, he's still at home. As far I've checked in on him every 4 weeks. I don't send the medicine because it's coming from patient assistance, but I check on him just to make sure. He did finish the course, or he's going to finish the course. Uh, it is a completed course of the first 12 weeks last month, but we extended the course to complete a full 16 weeks because we allowed patient assistance to send him a full 12-week supply on top of his 4 that he already had. He did have a viral load of not detected at week 6 of the new course of medicine. And so everything looks good. So we expect to see him back in January to know if we cured. So very unique case. It's a rare one. I haven't seen one like this before. So I definitely wanted to engage this and bring it into the conversation. I feel like it needed a little extra explanation along the way. So that's why I didn't just submit it as far as part of the cases at the end. So yeah, definitely wanted to spend time on this because it's unique. I hope we get a good result at the end. That's the main goal. And so I hope we made the right choice in just extending the course, allowing him to take a full course plus some extra based on following the guidance, following following the best we could to make sure we do the best we can for the patient. Okay. All right. Now we go to the next slide. And now I gotta speed up. All right, now we're going to talk about resistance testing. We're not going to go too off in the weeds, but I do want to just talk about how resistance occurs and how it does not. Because hepatitis C virus, it's not a very smart virus. It makes errors all the time. It makes billions of copies every day, but it's making 1 to 3 errors per replication cycle. So lots of different errors, and it's not like it's thinking about these things. They're just happening as it replicates. It has a faulty enzyme, so it's constantly making errors, not on purpose. That's just happening. So they're random at best. So this is how resistance is bred through this, is because it's a faulty replication cycle. Some of these mutations or errors will be susceptible or be likely to cause resistance to the drug at hand, and therefore they're going to replicate more because they're actually able to fight off or actually to replicate still in the presence of the drug, versus if they're mutations that don't work, they can become just dead viruses, or they don't change anything. Then those viral copies that are replicated are just going to be eradicated regardless. So there's lots of different errors that are occurring all the time, and it's just by the process of what works and what doesn't is what will continue to replicate. So it's not like the virus is smart. It's just that it's going to thrive wherever it can. If it can thrive with a certain mutation that is resistant to the drug, then that one's going to multiply more. So the most important thing that you tell patients is that partial and incomplete adherence is what can elevate these viral copies that have mutations to increase in likelihood. Because if you have partial adherence or incomplete adherence, that's when you're going to have these potential resistance viruses, allowing them time to continue to replicate, and then be the dominant breed of that patient's virus. And so it will become dominant, and then that's when we get into the point of resistance is present, and the normal direct acting antivirals are not going to work, and that's when we need to consider adding on either the bigger gun, which is sofosbuvir, patisiran, saprovir, trade name Vosevi, or adding on ribavirin to help out with that potential resistance as well. So lots of things to think about. And these are the things to counsel a patient on is just, we want to avoid resistance by having complete adherence to avoid these things from happening. Next slide. So the question is, when should you consider ordering it? If you're not sure, you can just reach out to one of us at the Echo team. And if you've got a case that maybe they've had a treatment experience or something, you can ask us. Or if you're not sure altogether and just want to refer to a specialist, if there's not a specialist in the area, then yeah, just reach out to us. But there's three main components that go into the hepatitis C medications: the NS5A, NS5B, and NS3/4A protease inhibitors or protease inhibitor. So these three are non-structural proteins that are identified that they have great significance in the replication process. And so by blocking these things, it totally disrupts hepatitis C virus from being able to replicate. Now, the NS5B, fun fact, it is a key part of the enzyme that copies RNA genome. And so because that one is very vital to the enzyme replicating, that one has a higher barrier to resistance because that specific protein is needed. And if you block that one out, then the virus can't mutate away from that because if you have mutations at NS5B, you're not going to have a replicating virus and it's going to become a dead virus and then it's not going to work. So that's why NS5B has a high barrier resistance, whereas NS5A still has a great function in the replication process, but is not directly tied to the enzymatic process of replicating. And that's why you see resistance appearing with NS5A versus the other two components of the structure of hepatitis C medications. So these are times when you can order it or consider ordering it. Resistance testing can be considered if the patient has a known trial and failure of an NS5A containing regimen or a direct acting antiviral regimen. So those are the new drugs. That's why when anybody says that they've tried and failed something in the past, try to figure out what it is, because I want to know, is it a new agent with a DAA or is it an older agent that we won't consider one of the newer agents that we need to consider moving on to the next option as far as retreatment? Because I want to know, can we use a first line agent or can we use do we need to consider salvage treatment for that patient? The other time that really is important for you guys as far as primary care providers in the community is patients who are treatment naive, they have genotype 3 and they have cirrhosis. That's in the simplified guidance. If you have those three things, then you're going to consider sofosbuvir, patisiran, trade name Epclusa. That's when you would consider doing resistance testing on the front end, because there is a specific mutation there that if it's present and you want to try to use trade name Epclusa, there is a risk that drug may not work. And so if you could use capillary prevention trade name Mavorite, that would be the time to use that. Or if you have to use it based on drug interactions or based on insurance preference, then I would consider doing resistance testing in that person for treatment naive genotype 3 with cirrhosis. So that's a time that you guys would really want to consider that. Whereas if they're treatment experienced and you're not comfortable with that and you want to refer to a specialist, then those kind of ordering resistance testing is not really in your game plan. You're just going to refer and let them decide. So those are kind of the times of when to consider it. And of course, if you're not sure, just reach out to us and we'd be more than happy to assist. Next slide. So I wanted to supply some information in the guidelines. The main thing of pointing out is what we just discussed with Hepatitis, trade name Eclusa. The main mutation that's of worry is the Y93, and the mutation is the H, and so it's changing off of what is normally there, and so that's been shown to have great resistance potential with Eclusa in that setting. So I included on the right side here the potential issues with the simplified guidance options of the pangenotypic items, highlighted both of them there, sofosbuvir and glycopyrrolate. Those are the main drugs that we're going to use, so we're not going to worry about the mutations up top because I don't anticipate you guys using either one of those. The first one is trade name Harvoni. The second one is trade name Zepatier. I don't expect you to be entertaining those in the most part. But yeah, this is that one case of treatment naive genotype 3 with cirrhosis. That's when you want to consider it. And then if you need to consider resistance testing for trade name Maverick, you could reach out to us to determine if that is necessary or not. Next slide. So then we also want to know, what's the best way to overcome resistance? Path of least resistance, you want to pick a medication that is appropriate for the drug at hand or for the virus at hand, whether they've tried something in the past or not. That can dictate what you might want to pick. Sometimes you may need to extend the duration. Sometimes you may need to addition of ribavirin. That does not mean that if there's resistance present, you need to do all these. Sometimes the first one is the only option you need. You just need to pick an agent that is going to work, that you know that doesn't have a potential resistance, and move forward with that one. But there is times in certain scenarios where these other things come into play, and maybe that is a time where you should refer to a specialist or consult us with the ECHO project to let us have a say as well. Because I don't want you to feel like you have to do resistance testing on your own. If you're not comfortable, reach out to somebody. Oh, fun fact that Bill's got, that Merck is actually discontinuing Zepatier. Didn't know that. That's a fun fact. We go to the next slide. So now we can go to retreatment options. Next slide. So this is when a person has tried and failed a direct acting antiviral agent. So we'll say if they tried ledipasir, trade name Harvoni, glycopyrrolate, trade name Maverick, or sofosbuvir, trade name Eclusa. If we tried one of those agents, we're going to call those the three main direct acting antivirals. Now that's when we consider these two options. So I put both of them in side by side. That way, the Eclusa, if they tried and failed a sofosbuvir containing regimen, aka Eclusa in the past, then your main option, your first option, is going to be the salvage treatment of trade name Vosevi for 12 weeks. You can't entertain Maverick along with ribavirin, but or without ribavirin for 16 weeks. Insurance may or may not prefer that, but I always stick with the easiest one, which is just one pill once a day for 12 weeks with food for trade name Vosevi. Same rules apply with Maverick. If they tried and failed Maverick in the past, with or without cirrhosis, you can entertain the Maverick plus sofosbuvir plus ribavirin. That's a ton of pills for 16 weeks. I don't really want to advise patients to try to do all that. So I'm always going to just stick with the keep it simple and ask for Vosevi for 12 weeks as my primary salvage treatment option for a patient who has seen a direct acting antiviral for a full course, and we're going to deem them treatment experience, treatment failure. That's what I would consider for both of these agents. So that's anybody who has went through simplified guidance and started on a pangenotypic agent and they've tried and failed it. I would consider trade name Vosevi for 12 weeks in either case under most circumstances. It is still recommended to refer to a specialist for retreatment. We talked about that a little bit, either the last session or the session before that. If they're straightforward and they don't have any other comorbidities or things going on, if you feel comfortable and we don't really need to do resistance testing or anything, you don't feel like there's any compliance issues, it just didn't work. So if they took trade name Eclusa for 12 weeks, you have no question about their compliance, and it just didn't work, and you know that the next option is going to be likely trade name Vosevi for 12 weeks. I don't know if you have to necessarily see a specialist. You may want to reach out to the ECHO team, and just, if you may have to talk with somebody as far as a specialist, to be in consultation with a specialist to make sure, but I don't know if it's necessarily required. If you feel comfortable and it's pretty straightforward, if it's a straightforward retreatment, that's fine. But maybe if there's other comorbidities or things to take into account, maybe noncompliance, maybe other things in play, maybe there should be a referral. But if it's straightforward, I wouldn't see why a primary care provider could not do it. There may be something on the PA that could require consultation with a specialist, but just let us know. Next slide. And the summary slide, evaluate patients for potential of issues and importance of compliance, be aware of and prepare for potential treatment interruptions. So that goes back to all the things that we mentioned. There's potentials, sometimes out of their control, sometimes in their control, that you just want to be aware of. The main thing about insurance changing at the beginning of the year, that's the thing I wanted to hammer home today, is being aware of that. If you're starting a patient on treatment now, that there could be that change in insurance, be aware of that. Consult a specialist if resistance testing might be indicated. It may not. Just reach out to us. And then, of course, best treatment option for first line simplified guidance regimen is Vosavy for 12 weeks, unless there's certain circumstances where we need to try something else. Okay. I want to make sure we got time for questions and also time for our cases.
A couple of just quick comments. One is that I think that case that you shared, Clark, was so helpful and powerful when we talked about treatment interruption. And I will literally say that even though I know this data and I work in this space, I have that figure right up kind of against the context because I think, Lindsay, as you were working through some of the questions back and forth with Clark, it's like it can get confusing and like exactly where are we fitting and what do we know? What do we think we know? And so that figure is something that's incredibly useful. Just really want to orient and highlight to folks. And again, available on the guideline website, a highlighted by Lindsay in the chat. So print it off or just know where to find it easily. And I would also say that the other 2 points you made, Clark, that really resonated with me is that one is that resistance testing can be complicated, but it's actually quite rare that we actually get it at this point in time. So that's why we're here, is to support that question. And retreatment is not as complicated as it used to be because we actually have clear guidance as far as the next steps. And so failure of treatment is not something that's routinely identified in the one-pager simplified guidance or the TH guidance, but it's not hard and it's not complicated. And that's exactly why this group is here. So that was a great overview, Clark.
Any questions about any of the cases that we discussed today during this session? Or maybe you've had actual cases that maybe something similar has come up. All right. And I just do want to touch on what Dr. Allen was talking about in reference to